I'm going to allow her to introduce herself because I always feel slightly awkward.
Thank you. So my name's Belinda Marks. I'm an advanced clinical practitioner and I work at Manorlands Hospice, Care in West Yorkshire. I've been a nurse probably for over 40 years. I know I don't look it, I've got eternal youth, but I've been a nurse for 40 years in various roles, but predominantly working in oncology and palliative care. So I've worked in the hospital, I've worked in hospices, and I've worked in community. So today I've only got probably 40 minutes, so it's really difficult to sort of condense everything. So I hope I don't rush things, and feel free afterwards to email me or ask me to clarify things. But I was just going to talk about end-of-life care and the principles and practices that we use. I am aware that people have come from a variety of backgrounds who are here, and also people from outside the UK. So things might be slightly different, but that's what's great about sort of palliative care. Sarah, could you show me my slides, or are they on for everybody else? They're on. Yeah, right, okay. So that's who I am. Could I have the next slide, please? So I'm sure for most of you, you're aware of what the diagnosis is for palliative care, but I just wanted to sort of chat through my understanding of what palliative care is. And normally it's for people who have a life-limiting, often terminal illness. And what we try and do is we aim to make that person as comfortable as possible by managing the symptoms. And that might include the physical symptoms, psychological, social and spiritual support for the person and their family. What's really, really important in palliative care is it isn't just about that person, it's about the whole family and the impact it has on all of them. So we deal with the whole person and the family. Okay, thank you. Next slide, please. So the principles that we use within the UK are, some of them have been around for a long time. One of them is the gold standard framework, and I'll go on and talk about that. One is ambitions, which is recently, it's a Department of Health document that we work towards in all organisations, and that has just been updated in 2022. What's really, really important is about having advanced care planning and having those conversations with both the person and the family. The respect tool that has been embedded into our practice in the last couple of years, and 5 priorities of care. So that's what we're going to sort of talk about, and then I'm going to talk through a case study and how this all comes together and hopefully works really well for the patients and families. Can I have the next slide, please? So the gold standard framework has probably been about for about 15, 20 years, and it's embedded in all that we do in palliative care. So the general practitioners use it, all the community teams, the hospitals, the hospices, we all use it. And hopefully what it does, it ensures really great care, gold standard care for our patients and families. And breaking it down, there's 3 basic steps that we follow. One of the most important things is identifying the patient. So identifying the patients early when we feel that they're in the last year of life. And that bit will be through GPs, the hospitals, the hospices, people coming forward, etc. We would identify that the patient is in the last year of life, so then we can put into practice and provide proactive care. So that will be doing things like, where are they on the prognosis? Do we feel that they're in the last year of life? Are they in the last months of life, or are they in the last days of life? And things are very different for how we do that. Also, so that we can highlight these patients and that they have priority when they're ringing the GPs, when they're looking for care packages, etc. We would then assess the patients. So once we've identified these patients and we feel that they're in the last year of life, we would spend time either ourselves from the palliative care team, the district nurses, the GPs, we would be assessing these patients and making sure that we were seeing them regularly, because as we're all aware with palliative care patients, they can dip off very quickly. The patients end up going into hospital, into the hospice with various symptoms. So it's keeping, supporting them through that, and that becomes hopefully person-centred. One of the most important things about the assessment is planning for the future, and that's when we would talk about advanced care planning, and I'll carry on and do that a bit later on in this conversation. And about planning, so what's really, really important for the person is that they have control about what's going to happen to them. So it's really, really important to have a conversation with them about what are their preferences, what do they want going forward. And that may change, you know, people have preferences when they're fairly well, that may change as they sort of deteriorate in the condition. What we want to try and do is, what is their preferred place of care and where would they like to die? And so that hopefully, if we put plans in place and the patient feels supported and that we're proactive and not reactive, it will hopefully reduce hospitalisation for that patient. And hopefully it will enable them to live well and to die in the place that they want to. And hopefully that might be, if it's home, that we're able to do that. Next slide, please. So in 2021, the new ambitions came out for palliative and end-of-life care. We had another five-year vision before that. I think it was 2016 to 21, and this has come from NHS England. And what's really important for us is that we live and breathe these ambitions in palliative care. And end-of-life care is care that affects us all, not just the person, but the family, but all of us supporting these patients. And it's really important that this isn't a tick box exercise and that every person is treated as an individual. We're all unique, we all have different needs, we all have different wants, and we need to capture this and work with the person and the family to ensure wherever possible this is achieved. That each person gets fair access to care. We all talk about these postcode lotteries where, depending on where you live, you get, you know, medication, etc. But it's really important that wherever you live, you get the same service. And within Bradford and Airedale, we have a fantastic service. We have Gold Line and things that possibly isn't happening in other parts of the country. So we are a bit biased to hear and what we're able to give. One of the other things that's really important is about maximising comfort. So making sure the patient is pain-free, that they're able to live the best life they can and be comfortable with that. And also the well-being, to keep them well as long as possible. We all know about often, and especially at the moment with all the constraints of the NHS and all the services, that sometimes services aren't coordinated. But wherever possible, care should be coordinated for that person. The worst case is when, you know, when I love to use Mabel. So Mabel, our patient, Mabel, so I go out and see Mabel. We spend an hour and a half talking about what she would like, what her needs are, and then someone else follows me in and starts to have those conversations again, or decide, you know, Mabel says that her preferred place of care is at home, and an out-of-hours GP goes and visits her, and she ends up getting admitted. What's really important is all the services should be talking. And we're very lucky in that with System 1 and EPACS, which is our medical records database, is that everybody can access that. So everything, we have an end-of-life template that we write everything on, that all of the services can see that. So they're able to look at it, see what's been discussed, And hopefully that encourages the services to be more coordinated. Also, with resources, you know, it seems silly that I'm going in and then another service comes in later on in the day to do a similar service or ask similar questions. It's really, really important that all staff are prepared to care. So all of us should be trained well. We should all have good communication skills, that we're all prepared to work for the benefit of that patient and family and all sign up to that. And also what's really, really important, and moving forward, I think this is going to be where a lot of the services and care sits, about each community is prepared to help. So that's about compassionate communities, about what's happening in a certain area, what services are available, what voluntary agencies are available that can support these patients at home. And the ambitions for palliative care comes from NHS England. Just pop that on. Thank you. Could I have the next slide, please? So advanced care planning is really, really important. So it's working with the patient and the family, what that person wants in the future. And this may well change. As I said earlier, what we want and hope for in the future is, you know, we might want to remain at home. When we get near to the end, we may struggle to be at home and may prefer to be in the hospital or hospice. But we should all be starting to have these conversations with the person about what advanced care, what they want in the future. And the plan will include, and it shouldn't be a tick box exercise. It shouldn't be, well, we need to do advanced care planning. So we rush in and we sit down with the patient and say, I need to do this. This can take weeks, and sometimes we never get there. People do not want to go there. So it's all about individualised care and working with the patient at their pace and where they want to go with this. But the plan may include things, what types of treatment and care that may be helpful in the future. You know, we can all think about, you know, if we were unwell, we would want to go into hospital and have every intervention possible to sort of prolong our life. But some people don't want that. So we have to talk with patients about what they would actually like. So some of the conversations we have sort of later down the line with people who are really poorly, and is, if you were to get a chest infection, a urine infection, would you want antibiotics? And they might say, well, if it helped with my symptoms or I didn't get any side effects, I may want that. And then we might say, so if those antibiotics didn't work orally, would you want intravenous antibiotics? And they may say, well, I might do. And we might say, well, that would involve going into hospital. What are your thoughts about that? And some people may say, yes, I want that. I want everything. Or some people may say, no, I want IV antibiotics, I want oral antibiotics, but I don't want to go into hospital. And we would talk about, well, that might hasten your death, you know, and as long as we've had those conversations. But we might talk about reversible things, you know, if you had a pneumothorax, would you want that treated, etc. But we go through that at their pace. And they may say initially, yes, I want to go into hospital. And we may start to have these conversations again later down the line. And that they may decide that they then don't want that, and that's absolutely fine. And this, we continue to have these conversations as the patient goes along the journey. What's really important is, what are their important values and future wishes? You know, so do they want to remain at home? Would they want a hospital bed? What's important to them? Is spiritual care important? Have they got everything in order? Have they got the family there? What is important to them? And we need to gather that information and have that information. What are the personal goals for care? Are they adamant that they don't want anybody helping them with a wash, that they want to do that all themselves, that would only want the family to do that? What's really important is also, if you've been really, really proud of the way your hair looks, your makeup, your nails. Nobody's ever seen you without your teeth, you know, your false teeth. That is really, really important that we capture that, because that is so awful for people if they've been really proud of their appearance and suddenly later on down the line they don't even get to brush their hair. So that is really, really important. That they understand their illness and the prognosis, and these can be really, really difficult conversations. A lot of patients and families will ask what the prognosis is. They may have been told, but they may want to ask again to see if they get a different opinion on that. What's their understanding of how their illness is going to affect them as they go further on? You know, what might be the symptoms? So it's about having those conversations, but going at the pace of the person and not just rushing these things. With all our patients and people, it's really important to build that relationship, that trusting relationship with people, so that they can trust you and they know that you're working with them. That is really, really important, developing that relationship. And concerns for things that they don't want to happen. So it's important that they know, you know, what don't they want. And one of the things that we can talk about here is, if your heart was to stop and you were to die, you know, would you want resuscitating? You know, and it's great watching Casualty. Sorry if you don't have that in the Canada and the USA, but it's a series about, you know, in an accident and emergency, and you have a nice hunky guy, an anaesthetist or somebody come and resuscitate you, and within a couple of minutes you're out and you're having a cup of tea in a chair. You know, things aren't like that. So it's offering what the reality is to people and what people don't want to happen. So, and also what's really important to the person and to the family is, if the person is the carer, what will happen with the carer? If something happens to them, is there a plan in place? Who's going to look after the carer, the children? So it's about developing a plan, getting other organisations involved to, you know, to support them with what will happen. And things here are also about lasting power of attorney, whether it's financial or health and wellbeing, and also wills, getting wills in place so people know that as time goes on, things will be in place and it will be easier for the family members. Can I move on, please? So respect is a tool that is used nationally now, or most places. We implemented this a couple of years ago in the Bradford and Airedale area. And it's a tool that, well, it stands for Recommended Summary Plan for Emergency Care and Treatment. And respect is a process and involves a form. And it is a tool that we've used where most people, we would talk to them about do not resuscitate and advanced care planning. Now the resuscitation part has been embedded in the respect tool. And this is a tool that we use with patients who have long-term conditions, anybody that potentially may die in the foreseeable future, just so we can put in place what that patient would want for if an emergency occurred and treatment was required. So across our area, it's used by the hospital trust, the hospices, the community team, the GPs are using it, the ambulance service looks at it, social services look at it. So everybody is aware that patients will hopefully have a respect tool in place. And what it does is it creates recommendations for what clinical care in an emergency situation you would want. So it's things about whether you would be more, whether you want to live longer, as long as possible, with as many interventions as possible. And this touches on what we talked about, advanced care planning. So would you want to go into hospital if you had a chest infection, or would you want just to have oral antibiotics at home and then see how things go? So it's all about putting those in place, and we talk through everything about resuscitation, and some people have a respect tool and are still for resuscitation. We talk about, you know, if you had a urine infection, anything that that you may want a clinical intervention for, and that we would either do that at home or escalate it to the hospital. And it's completed by either ourselves as advanced clinical practitioners, community matrons, clinical nurse specialists, GPs, hospital trusts, everything. But it's completed by the person who probably has a good relationship with that patient and is happy to sort of have these conversations. But this process is not a tick box exercise. So it isn't about going into that patient and saying, right, I need to complete the respect tool and we're going to do this. We bring this up as and when the patient is ready for it. Okay, thank you. All right, sorry, it's a bit of a whistle-stop tour, this. Right. Next slide. So priorities of care. So this is the 5 priorities of care for end-of-life care that we use and are fundamental to the care that we give. And these were developed following the issues that we had regarding the Liverpool Care Pathway. And this was the Liverpool Care Pathway was embedded in sort of end-of-life care for years and years. But there were lots and lots of issues. A lot of it was about poor communication. People put on the last days of Liverpool Care Pathway without the patient and family being aware of it. So not having communication, families not being aware that the patient was dying, people being sort of starved of nutrition and hydration because they were on the care pathway. So a lot of work has been done about making sure that we embed these priorities in everything we do in the sort of the end of life care. So the priorities that we follow and they're fundamental are, we all need to recognise when someone is dying. So there's a lot of training, a lot of support out there about recognising the indicative, can't speak today, of the indications of when somebody is dying. So lots of training happens for a lot of district nurses. We've put a lot of support in there so that we can recognise when somebody's dying and we can put everything in place for that person. Sorry, I've just lost my PowerPoint. I've just lost you. Sorry about that. So it's important that we recognise when somebody's dying, that we're able, where appropriate, and if the person's able to talk to the person about that we feel that they're in the last days of life, so they have an understanding of that, and also speaking to the family and carers about that. When I've spoke to a lot of staff and I've done a lot of training about this, a lot of people really struggle with having those conversations because they're frightened that if they get it wrong, and what happens if the person isn't dying and isn't in the last days of life. But for all the time I've done this, families and carers are more than happy that you've had those conversations and you've prepared them rather than that haven't been prepared. Because for a lot of people, it's really, really important that people who they love and care for are able to visit them where appropriate before that happens, so they can have those conversations. So we should never not have those conversations. But if you don't feel you're the one or able to do that, you need to get somebody who can have those conversations so we don't miss those moments. We need to, what's really, really important is that we involve that person in all the decisions, and also the family. We should not be dictating what's happening. It should be individualised care, what that person wants. And we need to be supporting that person and their family through this process. And we need to make sure that we create an individualised care plan for that person. So one size doesn't fit all, it's what that person wants. And that's where we go back to advanced care planning and the respect tool. If patients don't have capacity, that we have that information and we can do what that patient would want. Thank you. Could I have the next one, please? Am I all right? Right. So I'm just going to briefly sort of put together what might happen and what it looks like in real life terms. So we've got a lady, Mary, she's 76. She's been diagnosed with a breast cancer. She's got liver and lung secondaries. She's been discharged from hospital, not wanting any further treatment. She lives with a husband. She's been referred into our team for symptom control and advanced care planning from the hospital. And she's been informed that it's looking like she's going to be deteriorating in the next couple of months. Can I have the next one, please? So what things do we need to consider? And I'm only just going to touch base about things really, because I've got very little time. But what's really, really important is that we need to develop a relationship with this lady, with Mary and her family, so they can trust us and they can open up where appropriate, really. So what physically are we able to do? So we need to, as I said before, find out what's important. So the thing is, often with advanced care planning, and if we're proactive, we may have known this lady before, but we're obviously catching up now with this lady and we're just getting to know her in the last months of life. So we need to find out what's important, do some advanced care planning. We need to try and, wherever possible, retain her independence. So what's available out there that would help her with that? Within our services, we have allied health professionals, so we have physios, OTs, who can go out, help her. If she's got aids, needs aids and adaptations, we're able to put those in place. We need to manage her symptoms. So, so she's probably got breathless issues, she may have pain. So what can we put in place to help with those? So that will help with her independence and keep her as independent as possible for longer. What does she want long term? What's the preferred place of care? What's the preferred place of death? So if we can find that, we can put things in place for her. And what are we doing for, as she deteriorates, how are we going to care for her when she's dying? So is she going to manage herself with a little bit of help? Does her husband want to help? What we have to remember is a husband is a husband, and what we don't want is for him to become the carer. So it's important, wherever possible, that we put provisions in place so that she can be looked after, remain at home, and also support her husband to remain a husband. So we might think about fast tracking people. So that is when people are in the terminal phase, that we would commission a package of care to support people at home, and they may have a commission an agency to go in a couple of times a day to help with care and hopefully retain her independence. If she's struggling on a night and getting in and out of bed, or with symptoms and her husband's struggling, we might put some night sitters in. We'll get the district nurses involved, and they will be linking in and visiting regularly. We may have carers going in there through fast track. We might think about profiling beds, commodes, bedpans, anything that will help to sort of keep her independent and keep her at home if Mary wants. And also we might think about a just-in-case box, which is when, as people deteriorate, we have anticipatory medication in there. So for the main things such as nausea and vomiting, pain, agitation, and respiratory secretions. So we might put some subcut medication in there. So if the patient dips off and they're not able to swallow and take the medication, we've got stuff in there. And then I just wanted to talk about also within our area, and I think a lot of other areas now, if family members are wanting to give anticipatory medication, if patients are struggling with symptoms, we can teach family members how to give subcut doses of anticipatory medication. And I think as well, we need to think of aftercare. What happens with that patient when they die, about verification of death and care after death. Moving on, please. Thank you. Emotional care, really, really important. It's really important about emotional care for that patient, but also for the family, and who's important, so we can support both the patient and the family. And about having those conversations, going back to advanced care planning, respect, all the stuff about prognosis and planning for the future. We need to have those conversations, and it shouldn't just be left to clinical nurse specialists, GPs, everybody who's going in there, district nurses, everybody should start to have those conversations, or at least feedback that people need to be going in and having those conversations. Really, really important. As my husband says to me all the time, Belinda, you've got 2 ears, 1 mouth, so you should listen twice as much as you're talking. So it's about listening. And some of the best conversations you have is when you have those periods of silence. So it's allowing that person and that family to voice how they feel. And about being honest. And this is really, really difficult, but if patients and families are asking you difficult questions, being honest, and if you really struggle with those conversations, getting somebody who can have those conversations. Emotional care, again, about advanced care planning and respect. Thank you. Could I move on? Yeah. So about caring for the patient, but also caring for yourself. These are often really, really distressing conversations, and we absorb this distress day in, day out. So making sure that you care for yourself. But there's people out there to help you as well. But it's also about caring for that person and the family, linking in with GPs, district nurses. Within our area, we have palliative care support teams, which are like a hospice at home team. The hospice, we have a family support team that can offer patients and families counselling, financial support, social support. Within our area, we have a gold line, which I suppose we're very, very lucky about, which is where we have clinicians on the phone 24 hours a day, senior nurses and allied health professionals, where patients and families can ring up if they're concerned, and they can speak to the team. They can get GPs, out of hours GPs out. They will give advice over the phone. It's a brilliant, brilliant service. And also about financial support for patients and families. What's really, really important is people often have to give up work to look after the loved one, or the person has to give up work. You know, it's making sure that we make sure that they've got all the benefits that they have, that they're available for grants, and our family support team or carers resource will do that, but ensuring people have everything that they need. Thank you. So just to summarise, really, hopefully, I'm on time. Right, summarise. Everyone is unique, and what if you don't take anything away other than this, but we're all unique, we're all individuals, and one size does not fit all. And that's what's really, really important about having relationships with patients and families and finding out what's important to them. And it doesn't become a tick box exercise. We have to understand what they want and make sure we document that, and wherever possible, put that into practice. Being proactive, not reactive. If we can get it as in the gold standard framework, if we can identify the people early enough, we can put all this in place so we're not playing catch up in the last few weeks of life, which is really difficult sometimes to build those relationships. We need to all be aware of what services are out there and utilise them and work together to support that patient. And also be equip yourself to have difficult conversations. And if you don't know how to do that, get someone, but also get training. There's lots of stuff out there. Sarah, next one, please. And that's, thank you. Any questions? I couldn't see the time, so I hope I'm on time.